Good evening, everyone. I'm really excited you're here. Welcome to our True Women's Health Facebook Live event. I'm Dr. Diana Bitner, co-founder of True Women's Health. And tonight I'm excited to invite Dr. Mili Thakur with us. We're going to dive deep into the world of genetics, and we're going to talk about direct-to-consumer testing that you could buy on your own versus those that are ordered by a physician and what those differences are. So I'm really excited to get into this topic. So I'd like you to meet Dr. Mili Thakur. She's a gynecologist, women's health doctor. I would love to hear your story, Mili. How did you get into your career and how did it turn out into what you're doing today?
Thank you, Dr. Bitner. I'm excited to be here and connect with your audience. So basically, my background is in women's health. I'm an obstetrician and gynecologist practicing for over 20 years. And I specialize in reproductive endocrinology and infertility management. So that's what I do every day. And I'm also board certified in medical genetics. So it's a very rare combination of those specialties coming together. And the history behind it is I like to be at the forefront of science. I like exciting stuff, and I like to help families. And women's health and babies are very exciting for me.
Yeah. Well, when I practiced OBGYN before I got into more midlife menopause and sexual health, I would refer patients to you all the time who had fertility concerns. But I remember really getting to know you when we worked together. Boy, it's been like 3 or 4 years now, where we helped develop the, how do we say it, the fertility preservation for young women with cancer. So we got to work together on essentially how to freeze eggs and embryos for women affected by cancer. So before their treatment or their chemotherapy would take place, right? You taught me a lot about all of that. So it was great to get to know you. And so how did this work turn into you founding your own company, Genome Ally? How do I say this?
Genome Ally.
I love that, Ally.
Yeah. So Genome Ally was founded because I was seeing these gaps in women's care. Like by the time they were reaching us in the healthcare system, things had been missed or they had already gotten affected. So like, as you were saying that when we were working on the fertility preservation program with oncofertility, sometimes I would be face to face with a young woman who's there discussing chemotherapy and hopefully preserving some eggs before, they can do treatment. But when I would look at their history, it was pretty obvious to me that they had strong history and they could have been picked up before the cancer actually became a thing. So those gaps were the ones that motivated me, and I wanted to improve the access to care. So instead of being in a traditional brick and mortar kind of system, I now founded Genome Ally, which is a telehealth medicine practice. And, it gives access to patients all around Michigan. I'm able to see patients from West Michigan. I'm able to see patients from East Michigan. And then I'm licensed in like 17 different states. So I'm seeing patients from all around the country. And patients are getting access to care from the home. And hopefully we are able to pick things up that can change the trajectory of a young person's life.
Right. Well, I've got some notes here. I want to make sure that I stay on track here, but I'm really interested to hear you talk about the difference in tests that people can just get in the marketplace, the direct to consumer versus medical grade genetic tests. Here at True, we do some, which we'll talk about, but I would love to know your sense of, tell me about the difference.
Yeah, so a direct to consumer genetic test is a test that patients can actually order online without the help of a healthcare provider. And a DNA kit can come to their home. They can do buccal swabs and send it back to the company. A good example of that could be tests like Ancestry.com or 23andMe, that can be ordered by just ordering a kit. While medical grade tests are the tests that are typically ordered by a healthcare professional, and they are done in like certified laboratories, and the results are more comprehensive and more clinically applicable. So direct to consumer tests are good tests for like finding out just something little bit about yourself, but like a medical grade test is one that is indicated clinically, and then the results of that can then help guide your healthcare team to take decisions and change the course of whatever was going to happen.
Right. And we don't want to have partial information when we're making huge decisions, right?
Yeah.
I remember when we worked in the oncofertility space together, it's like it never had really dawned on me that, of course, this young woman has cancer. Could that cancer be something that, of course, is genetic? And even if we are able to preserve eggs, what are the chances that her offspring then would have the same?
Yeah.
And, were we willing to take those chances? So, that's really interesting. So that sort of moves into like preconception genetic testing, right?
Yeah. So, one of the main things to kind of consider is, as women and as individuals overall, we have been interacting with the healthcare system for so long that we just assume that our history's in there. They've asked us those questions number of time, and every person has like 4 or 5 different doctors that they've seen throughout their history. They just assume that the right test will be offered for them, but I think the onus lies on the individual and for the woman to kind of know what tests are out there and then be able to ask for them. So one of the common tests that we use for those who are on a family building journey is a preconception carrier screening. So each one of us has the same 30,000 genes, but because we come from different parents, there are small changes on those genes. Most of the time, those changes just make us unique, don't cause disease. And many a times we are also carriers of serious disease, but it doesn't affect us. These disorders are called autosomal recessive conditions. So between two people, at least one person is a carrier of a autosomal recessive condition. Common conditions that you might have heard of is cystic fibrosis or sickle cell anemia or spinal muscular atrophy. The incidence of being a carrier for such a condition is very common. But because these conditions don't affect the individual, usually there's no family history, and it doesn't affect the person themselves unless they partner with somebody who's coming from a different family. So if two people are going to have children together, if both of them are carrier of the same condition, then 1 in 4 of their children could be affected. Most of the time in the current health scenario, an affected child is born and then the parents are tested and come to find out, oh, by chance these two people who
Right.
together were carriers of cystic fibrosis or spinal muscular atrophy, which is a serious neurological condition,
Right.
and then they find it out. So
Right.
preconception carrier screening is a buccal swab ordered by a doctor, or a healthcare professional, and it can be done for a number of different conditions. We call them panels, and then the results of that tells the individual whether or not they are a carrier of a condition, and then their partner, if they are partnered, can test and see if they are the carrier.
So how would you decide who gets what test?
So right now we have moved away from like ethnicity-based testing, which is what used to be. So if you were from a certain ethnic background, you would get a small panel of whatever conditions were prevalent in that group. Now in my practice, we use like a wide panel of like 400 plus conditions that are there in different populations. And basically all of those conditions are actionable. So in that panel, most of the conditions are autosomal recessive. That means they affect the baby or the offspring only when both partners are carriers.
Right.
But then there are about 30 plus conditions that are X-linked. So women sometimes on their X chromosome will have a change, and then their boys are more likely to get it. So unless this test is offered to a woman and in a big panel, they would never find out. Only time they will find out is when there is an affected baby.
So when you say these things are actionable, if someone were thinking, wow, I am on my journey and I want to know, and I get these panels done, what do I do with the results?
Yeah, so if an individual is a carrier of a condition and their partner is not, then at least they will be reassured that their risk is greatly reduced to have that particular disorder happen to the child. That's number
Right.
one. Number
Yep.
two is if they're still single and are not in a committed relationship and they're a carrier of something, they could bring it up and say, I'm a carrier of this. Would you
So
want
if they're on a date, they can ask for a Q-tip and they can scrape the inside of their mouth and send it off. Is that it?
Yeah,
And
I think that's what's going to happen in the future. Like, why would we want to not know if you're partnering with something? Obviously, relationships are built on more than what genetics is. Like, if you're going to commit to have
Right,
children together, it would be good to know. The third thing is that these conditions that are on the carrier screening panel, when they affect the child, because they're enzyme deficiencies mostly, the food of the baby has to be changed. There are conditions in there where the baby can't breastfeed right after. And most of the time, these conditions take multiple hours to like find out, or sometimes days or months. So in those conditions, that baby can have brain damage while they were given the wrong food. So I think knowing that you are a carrier couple, you can flag that newborn screen, and I'll talk about that. And also you can tell the pediatrician and say, hey, both of us are carriers. Make
right,
sure the right formula for this baby is available in the hospital. And
right.
I'll give you a short story. Like, I used to work at Children's Hospital of Michigan in Detroit as when
Yep,
I was a fellow, and I had to airlift somebody from here. They were like born in Traverse City. The baby was born in Traverse City. They didn't have the right formula. We just found out, and then the baby was brought to Grand Rapids, by a 2-hour ride,
right,
and they still couldn't find the formula here. So the only way we could get the baby out to Detroit was in a flight, because it was a snowstorm. So all of that drama wouldn't happen if we knew that, okay, a baby's coming who's going to need this extra care.
sure,
And for some couples, the option becomes that they want to prevent the disease from passing on. They know that both of them have it. And the way to do it is options like either using IVF with genetic testing of embryos to see that the affected embryo doesn't get transferred.
this is just amazing to me. If you can just slow down and just like, so say again, so you and I know what IVF is. If you could maybe just briefly explain to our audience, like, and then, wow, you're testing for the genetics in the embryo.
Yeah. So if we knew exactly what the patient and the partner carry, so, and if it's the same disorder, so say, for example, the patient and the partner both are a carrier of, say, sickle cell disease, right? One of their options could be that they can sign up for IVF, where the woman takes injections for 2 weeks and then goes through a procedure called egg retrieval, where we take the eggs out. And then those eggs are developed with the sperm. So that we inject the sperm, fertilize the egg, and then multiple of those embryos can grow to a day 5, day 6 stage. We call it blastocyst. And it's almost like a microscopic soccer ball structure. Those embryos are tiny and they have this soccer ball structure, and you can take out 3 or 4 cells without hurting the whole embryo, which could have 150 to 200 cells. And if we knew ahead of time that this is a carrier couple and they've signed up for that kind of testing, then we could test the embryo and say, okay, this embryo did not get any of the affected mutations, or this embryo got just a carrier thing like their parent, which is okay to transfer, and this
Right.
one is completely unaffected. So we would transfer embryos that will not have the disease, you know, that would be passed on to the embryo. But
I
it's,
remember when I was in practice, this was so novel. I had a couple who she had had 2 miscarriages at like 24 weeks. So just a horrible, sad history where she lost 2 babies. Well, maybe it was 22 weeks, but very early. And turns out it was a genetic condition. And I remember I had to write letters to Priority Health asking if she could go out of network to Chicago to have IVF and have her embryos tested. And they have 2 children. And if it hadn't been for that testing, they wouldn't have been able to have a family.
yeah.
And it just gives me shivers still to remember like the joy that they got to experience because they just wanted children so badly.
Yeah, and Diana, this is what we're trying to change. We want to prevent that pregnancy loss from happening. We want to prevent that family getting a special needs child, who's going to need a lot of like help without knowing, we can't be prepared for that. So for some families, IVF may not be an option. For other families, changing the course of the pregnancy may not be an option. But at
Right.
least the mom and dad of the baby are not like left to like figure out what this is and why their child is different, they
Right.
actually are prepared, and the medical team's prepared for taking care of that child, providing
Right.
it what it needs. And we've seen it with, like, because babies are so small, right? Every hour counts for what is being given to them and what kind of like support is available to them. And many mothers, and I take care of like people with differences. That's what I do, right, with genetics as my fellowship. Moms of children who have those kind of disorders, they are fine taking care of those children, but they always regret why they weren't in the know.
Right.
Why?
And they're like, we accept what we've been given. We do everything we can to support our child. But I've heard it, I think the best way is, I hate that my child has to suffer this.
Yes.
And it's just heartbreaking. And again, I've seen so many parents say, why did this have to happen to my child? Why didn't I know? Why didn't we have more information? So,
And
that's
when women that I've talked to and taken care of, they say it was just a simple test, a buccal swab that possibly my insurance could have covered. I would have done it. I would have wanted to know. And in Michigan and in other states in the US, newborn screening is done on the baby. It's a test that's done when the baby's still in the hospital within that 24 hours when the mom and baby are recovering from a heel prick. And you wouldn't believe there's like 280 plus children in Michigan that are born with these rare conditions, and majority of them, it comes as a surprise to the family that this is happening. And there is like at that time, because I worked with the newborn screening team as part of my training,
sure.
you're scrambling, the mom and baby, and hopefully the whole family is celebrating the birth, and then
Right.
suddenly you're making a phone call and you're saying, it's like it could be possible that we are seeing in the newborn screening program that the child could have a serious condition. You got to come back and
Right.
you need to do X, Y, and Z test. Like, that's very scary. And,
It's very
having
scary.
lived that experience with so many families, all patients that, work with me, we offer them the preconception carrier screening.
Sure.
We provide them the pre-test and the post-test counseling. So like they know what they're being screened for, because there is like a set number of disorders there. We're still not looking for all the genes in there.
Right.
And then the post-test counseling is, okay, you have come back as a carrier of this condition.
Now what do you do
It
next?
affects your
Yeah.
health, and, move
And
forward.
that's so important, because just getting a test off the internet and sending it off to a lab and then finding out you have something, to me, that seems even scarier, right? Like, okay, now I know this, and now what do I do about it?
Yeah, but for like for all the direct to consumer tests, because they have been developed for a curiosity sake, they're not medical grade tests. They don't look at the depth that other tests that are medical grade look at.
Sure.
So even if somebody got a genetic test through a direct to consumer test and it said they're not a carrier of cystic fibrosis, when they come see a healthcare professional, we will have to retest, because the difference between the two setup of the test is, in a
Yeah.
direct to consumer, they're only looking at 4 or 5 spots in a certain area of that
Sure.
gene, while in a medical grade test, mostly we use a technology called next gen sequencing. So we are sequencing the gene as best as possible. Still, genes can't be sequenced end to end, and there are gaps in there, but at least we are top of the line. We are looking at everything. So once we have a medical grade testing tell us that, okay, this person is not a carrier of cystic fibrosis, only
Right.
then we rest assured.
Nice. I understand.
Right. Yeah,
Yeah.
because in a direct to consumer test, it's like they're looking at snippets.
Right.
They're not looking at the
Looking at
whole
the whole
book.
thing.
Yeah,
Right.
they're just like opening some pages and saying, okay, it looks like you don't have this trait or you have this trait, and it's good to know, but it's not actionable results.
Understand. That makes a big difference. So then let's switch gears a little bit and talk about inheritable genetic testing for cancer risk.
Yeah. So 1 in 4 people are at risk of cancer, and about 10 to 15% of those people are going to have inherited cancer risk. That means that there is some genetic change that they have inherited from their family, unknowingly, of course,
Mm-hmm.
and that puts them at a higher risk. And, because of like recent public figures that have shared their story. There is more and more information out there. A common gene that's been associated with breast cancer is like BRCA1 and 2. And it's very common to find that change in women affected with breast cancer. And then there is another condition that's like becoming more in the public awareness, Lynch syndrome, that puts at
Right.
that risk of like uterine cancer and ovarian cancer and some breast cancer. So there
Right.
are these conditions that are inherited from a parent to a child, and they put that individual at a higher risk of cancer. So what happens in these conditions, just to like just brief about their genetics, is that we all have two copies of the same gene. So if somebody is at a regular risk for cancer, doesn't have this inherited risk, they would have two BRCA gene copies, which is a tumor suppressor gene, DNA repair gene. So those both the copies work. And if by chance over the course of your life some exposure happened, or you just got exposed to radiation or whatnot, in one of the cells, even if one of the copy got changed, you have a backup copy that takes care of that cancer prevention, and you're okay. But individuals who are born into a family that had that inherited risk actually already has one of the copies that's mutated, that's broken, doesn't work from the birth.
Right.
We are running on reserve with the backup copy. And then something comes along and all of us are exposed to some one or another exposure. It could be just basking in the sun outside
Right.
versus eating something. And then that other copy changes in one of the cells. And then when both of those copies are gone, then there is not cancer prevention. And then, that one cell then starts to divide and cause the cancer. So
Right.
women with inherited, and actually men and women are equally affected with these conditions because, they are passed down in the family in that way. We call it autosomal dominant. And basically what happens is they have early cancers.
Right.
Like,
So
let's
scary. I have a patient with the BRIP gene mutation
say,
recently, which is a really high risk for, how do I say it, BRIP?
yeah.
High risk for ovarian cancer. And
Yeah.
so she had her ovaries removed. And so now I get to help her with menopause symptoms. Another patient with PALS2, mutation. So it's
Yeah.
not uncommon. This is not
Yeah.
infrequent.
And the more we are looking into it, so there's a condition called Li-Fraumeni. It's like P53 is like an important gene that works in all cells of our body. Is like when the cells divide and the cell cycle happens, it's a very important checkpoint gene that checks and makes sure and only lets the cells that are doing well go forward. And in families that have that change, there could be a major problem with like cancers happening to young 20-year-olds sometimes.
Yeah.
And those individuals' life trajectory is completely going to be different. So for inherited cancer panels, what we usually do is the biggest cue to like look into this is if you have multiple family members that have either the same kind of cancer in a young age and they all are kind of seemingly concentrated on one side of the family. That's one cue.
Right.
The other one is if there are these rare forms of cancers that are happening in the family, even with one person like that, like stomach cancer or somebody with pancreatic cancer or gallbladder cancer, that just points towards make sure we look at this.
Right.
Or if there are like multiple, both male and female individuals in the family that have these speckling of different types of cancer. Like there's some prostate, but then there's some breast, and there was an aunt that passed away from ovarian, those kind of things. So when an individual is aware that there is something that is called inherited cancer, then when you are at a social gathering with your family, you were talking, you also ask about, oh, what did aunt so and so have?
Exactly.
And then if they say ovarian, like ovarian cancer is one of the giveaways of like it doesn't usually happen without a change. Right, unless there is too much exposure. So like if you heard that one of your aunts or somebody in your family had ovarian cancer or male breast cancer, it's an important one. Prostate cancer that happens along with other family members having breast is a BRCA1.
That would be a reason. Yep.
Yeah.
So if any of you listening out there, please feel free to ask any questions. We've got the comment open. So happy to take your questions. Again, I could listen to Dr. Thakur talk all night, but just want to make sure we're getting to what you want to know.
Yeah.
So sorry, Mili.
Yeah,
So
no.
And then when you, let's say you see a patient who has questions about this, what are your first steps? You probably take a great history, of course.
Yeah. So I think the biggest thing that I do is like I sit down with them and, like I said, we do telehealth. So it's very comfortable. And you can they can share the history with me and I draw actually a family tree. And if it's like a couple, then we draw both sides. We do a 3-generation history and then ask questions. And then there are guidelines that are available. So NCCN is a professional organization that puts out those guidelines. And then if we meet criteria, so we look at like, okay, this person meets criteria for getting tested.
Right.
And, we would then order the test. And usually the insurance will pay for it because we will provide documentation and say, this is why this person needs it. And the results come back usually in between, I would say like 2 to 3 weeks of time. I have another follow-up meeting and I discuss the test results. Going into an inherited cancer panel is slightly different than a preconception carrier screening. For preconception carrier screening conditions, most of the time it doesn't affect the individual's health.
Right.
But for cancer risk assessment, what we usually do is do the pretest counseling, but then we also have a very interesting rule that is out there, which is called GINA, GINA. So it's like a non-discrimination based on your genetic test results, right? If we tested somebody, the health insurances or employers, and if somebody was found to have cancer, the health insurance or employers can't deny a person coverage or deny them a job. Yeah, but the life insurance is out of that.
Unfortunately.
Yeah.
So I always tell patients before they get tested to make sure they've already got their life insurance or disability insurance set, because to your point, once you get tested, that's on your record and can affect your ability to get life insurance or disability insurance, but not a pre-existing condition for terms of employment or insurance, correct?
And also I think this kind of testing has to be done with like somebody who's very well versed in like helping the patient through that experience. Like it could be life changing, it can be very empowering, but if not done in the correct way, and like if you did something like a direct to consumer test for a cancer panel and found out that you have BRCA gene, you don't have a professional that's working with you, it could come as quite a scare.
Yes.
So I think physical changes are expected if you are a carrier of inherited cancer gene. And it's best to have it done with a medical professional. So there's like 2 types of medical professionals that usually will provide that kind of support. One would be your obstetrician, gynecologist, reproductive endocrinologist, somebody who's like very well versed in that, or your internal medicine doctor. But the second group of individuals is a genetic counselor. We have a whole profession of individuals, that they go to school for 2 years and do a master's in genetic counseling. And basically they help individuals take that decision with an informed consent, with pre-test counseling and then post-test counseling. So you feel comfortable doing it. You know what kind of results to expect, what are my percentages, and what am I going to do if this and this happens. I think that's what eases that whole situation.
Right. So many people get nervous about like, okay, now what am I going to do if it's positive? And then what do I do if it's negative? So having that informed consent and what all it's going to imply is just critical. So I just applaud you for doing that.
Yeah. And I think it's like talking to hundreds of families like this. Once the initial impact is gone, right? If once a young person who's not affected by cancer, hopefully, gets that information, then, the initial first few weeks and months, you have to do something. You might have to go to the doctor, or you might have to get checked out. You might even need preventative surgeries or go on a certain medicine, do some diagnostic testing, and it feels like overwhelming at that point. Once they've survived, and then they are able to see milestone for their children, or able to do whatever they need to do and live a long life and not get impacted by chemotherapy, then they look back and reflect and say, yes, we did the right thing. This has changed my life. There are thousands of advocates on social media and like families that have this kind of stories. they feel thankful that they have all these years
Right.
added to their life.
Right. But at the time, to your point, it's a big shock. It's very
Yeah.
scary. So again, that's why that informed consent is so important.
Yeah.
And then having that information can be just so valuable.
Yeah.
Yeah. My patient who had the PALS gene, she decided to have the prophylactic mastectomy. So she had both breasts removed. She had reconstruction. She's very happy with the process. It took her a long time to decide, to go through with this. But once she did, and we had all the steps lined out, if she were positive, what would happen next, that gave her a lot of reassurance. And, then she was able to go through the surgery. She was very informed. She did it, on her schedule. And now she's just so grateful that she gets to do it. The other thing is, before she was very concerned about taking hormone replacement therapy, estrogen, and now she can take estrogen without being concerned about it. So again, it creates a really big relief. So the next thing, you want to talk a bit about recurrent pregnancy loss genetic testing.
Yeah. So I think any pregnancy loss is like a deep and emotional blow to a woman, and many a times I have seen, and this is like a very important point to point out, women seem to blame themselves for the
right.
loss.
I think they did something wrong.
Yes. And I saw somebody a few days ago, they had a pregnancy loss. The loss was because of a birth defect called anencephaly. It happens from time to time. She was on folic acid, which is a preventive measure for anencephaly, but it still happened, and she had to go through a loss. And she thought that because she went to orange therapy and did exercise during the first few weeks of pregnancy, that's why it happened, until she got to see me and we talked about it, and we said this is this is a birth defect. It can happen to anybody. So the important thing about pregnancy loss is, because it's such a personal journey and everybody has to grieve that process, if we had some answers of why this happened, and mostly if the answer is something was different about this embryo or this pregnancy, it didn't have the right genetic information, it wouldn't have made it anyways, then I think it helps. So there are two different types of
a lot of peace around it, right?
Yes.
To your point. And I too took care of so many women who had pregnancy losses and did the D&Cs and all of that. And I would always say, why do you think this happened? Like, what are you afraid of? What do you think that you did to cause this? And every time someone had a reason, a glass of wine they had, or having had intercourse right when they were pregnant or something, they're so afraid that they caused that loss. So again, and you said there's two different ways you go about
different tests. Yeah. So mainly the thing is, when a pregnancy loss happens, and a lot of scientific studies have shown that 60% of the time something's abnormal with the embryo in how the genetic information was passed to the embryo.
Right.
When we all have 46 chromosomes in each one of our cells, and 23 come from the mother's egg and 23 from the sperm, and they come together. But from time to time, an extra or a missing chromosome comes from either the egg and the sperm, and the embryo gets an abnormal number. So if it is like, instead of 46, it's 47, or if it is 45 or 44 or any other number, that embryo runs out of all the information. It doesn't have adequate information, or it has too much information in a chromosome, and that causes the loss. So 60% of the losses that are happen because of a condition called aneuploidy, where an extra or a missing chromosome is there. And so the first category of test is, if one loss can happen to anybody, but if the second loss has happened to the same woman, then they are offered a test to test the pregnancy, if they're able to collect that information, or if they're going to do a D&C and the doctor can test that. So we call it products of conception testing. And basically what it tells us is whether or not that loss happened because of a embryonic factor, that means there were chromosomes were abnormal, or was there something that led to the loss of a genetically normal embryo.
Right.
So I think if a woman's going through the first loss, it would be great if they get offered the test. But at least if the second loss is happening, or anything beyond that, they should be offered that test, and we should have information. So
Agreed.
The loss is collected, sent to a genetic testing company. They also ask for blood from the mom and dad, and then they look for information to see, was there anything extra or missing?
Right.
It's a test that we call SNP based assay. So they look at like information, and then they can even tell whether it came from the mother's egg or from the father's sperm. And most of the time, it only happens once. Like this kind of genetic abnormality is just a random chance for most of those type of test results. Then the doctors don't have to change plan for the next pregnancy. You can still try to conceive the same way and do the same thing. But if there are some conditions called balanced translocations, when it comes back abnormal in the embryo, then sometimes we test the parents for that second test that I was talking to you
Mhm.
about, which is called a karyotype for the partners, for the mom and the dad, to make
Mm.
sure that they carry the 46 chromosome in the usual way.
Yep.
Sometimes, portions of chromosome will switch
They're
places with
flipped,
another
right?
one.
Yep.
So it's okay with like that individual has all the information, but pages of a book have been flipped in a chromosome. So when it gets passed on to the pregnancy, the
With an
information
egg,
becomes
right?
unbalanced. And these individuals, if they are not aware of this, will go through miscarriages. Some of the women that I've seen that didn't get offered the test had 10 plus miscarriages. Every time it's
Mm.
unbalanced information, nothing's going to help.
Right.
And, if we find an individual who has this kind of translocation, is what we say,
Yep.
then again, there is an option of like testing embryos and only
Right.
transferring the embryo that is balanced for that information. We
Right.
call that kind of testing IVF with PGT-SR. SR is like structural rearrangement. So we can see, okay, did the embryo get all the information like how it should be? And then transfer only the balanced one.
Right.
Other times, there are options for individuals who don't want to do IVF where they can actually use donor gametes, like don't
Mhm.
use the egg or the sperm from the carrier parent. And then for other families, it just means that they're going to expand their family any other way. So donor embryos or through adoption or
Adoption.
foster parenting, like at least it tells them that, what is the reason that they're kind of going through these
Right.
losses.
Because I have some, patients who are like, I can't suffer another loss. I can't do it. I
Yeah.
can't do it. And so instead of just having to stop, it's having that information that makes a difference.
Yeah. And
So,
again, it's actionable information. That means that information can change the outcome and
right,
move the family at least in a direction that may be suitable according to their values instead of being in the blind. Because I think one of the things that I feel very strongly about is we can't take good care of ourselves if we are in the blind.
correct. And we say that true all the time is knowledge is power. And if you know about your body, you can make the best decisions for yourself. Again, based on your values, based on your desires, based on what really makes you tick and feel like yourself.
Yeah, and I think facing that forward, like if you knew, you can handle anything. A woman who's working in this day and age, or is a mom of kids, or has been through everything in her life and is
Right.
now a 60-year-old, can take care of anything that is in front of her. What she can't take care of is if she's
What you don't
unaware.
know.
She just didn't
Right.
know there was this possibility, and then bam, it hits that person. They're like blindsided.
But so much better, right, than to know than to have a surprise and all of a
Yeah,
sudden have something and not know why it happened versus having been prepared,
yeah.
right? So,
And the
so
difference between these tests is like the main important thing between the test is the comprehensiveness of the results.
right,
Like when we do medical grade tests ordered by a health professional, the comprehensiveness of that test is wider. They are done through certified laboratories that are clinically actionable. All of these tests have been validated for their analytical efficiency and also for like clinical application.
right. Well, too, you talk about accuracy, right, and reliability. Like if we're going to make life-changing decisions for a family, for a couple, they have to be reliable, right? This has to be legit. We have to trust it. We're gonna put a lot of weight on this.
Yeah, and I think that's what the medical grade tests provide. They provide a platform to get pre and post test genetic counseling. You're well aware of what's going to be tested. And then also, I think big on the minds of people is how is my data, interpreted. So because the
Yes.
interpretation of the result is very important. You can look at a genetic change and disregard it if the laboratory wasn't looking for that change. While in these clinical medical grade tests, if they see a change that is we call it variant of uncertain significance. That means it hasn't been reported with disease yet. They still kind of tag that result and say, it seems to be in an important gene. We don't think it's been reported in another human person before,
Right.
but after 6 months or a year, they're going to look back at the literature and then it can be upgraded to something called pathogenic.
Exactly. It's just really interesting because we'll get reports back, and again, that variant of undetermined significance. It's like, what is that VUS? What does that mean? And so it's good that the labs are keeping that data to see if then we find out what correlates with that gene.
Yeah, and it's like that individual, and I've had like women who were given test results that were either positive or negative or variant of certain uncertain significance. They keep it in their records. Like I've seen,
Right.
I have a patient of mine whose daughter came to me. So she had kept the reports from her birth.
Wow.
It's like women are good keepers of like records. So like
Yes.
once you've told a woman that there is something that needs to be rechecked in a few years, make sure you don't.
Right.
They will take care of it. They will pass it on to their offsprings. Most of the time they're very good in like
Right.
communication, and they'll
Yeah.
watch out for their son and their daughter-in-law, and
Yeah.
like if you change the life of that woman by giving her that empowerment, I think the whole
Mhm.
family then goes on a different trajectory.
Right. Exactly. Tell me about oversight or regulations. Like, how are these labs regulated?
So most of the labs that do specialty tests, are regulated by FDA by a discretionary role. So because these kits are made by the company and they are coming back to the company in a medical
Right.
grade system, there is a way of certification and there is a way of how they are regulated. But in direct to consumer tests, because those tests are not medical grade, the regulation is different. So they have to report out the results and they have to like follow the consumer guidelines. But because they are not the same level, they are regulated differently. And the important thing to kind of consider in that whole thing is I could do a 23andMe or any of those ancestry.com type
Right.
tests for fun or for curiosity or just to be aware, but I wouldn't consider them as proactive health management.
Right. But the other two thing is about privacy because, for example, I'm adopted. I don't know any of my birth father's history or who or where this person and family is. I wouldn't want to do an ancestry.com or a 23andMe because then that information is out there. And that's not something that I want to do at this time. So, what I love about these tests is that there's privacy, right? It's HIPAA protected. The data is not shared, right? Unless there's permission given.
Yeah, and most of the times, the with now open notes and with like patients having access to these
Right.
results, it really becomes important to keep them with you as well. Like
Right.
most of the time, I've kind of felt that some individuals would say, "Oh, I got a test last pregnancy. I
Right.
just don't remember what it was," and they said everything was okay. I think
Oof.
that's one
Yeah.
one of the key things to kind of remember from this is one is genetic tests are all different types, right? And genetic test doesn't mean that all single gene in the body have been looked at. So
Exactly.
you have to know which test has been looked at and what those results mean. And if it's okay to forget it, but like have those for your record. So like when you go for your next pregnancy, you can say,
Right.
I've had a preconception carrier screening and here's my results. So they don't do it another time or miss something in that whole
Right.
thing.
There's even a test we do here at True called GeneSight. I'm sure you're aware of that, but it's a swab of the mouth or a buccal swab, as you say, that looks for how women process certain medications, such as antidepressants, meds for anxiety and depression. And so it's been a really valuable test to have here. So yeah, all these tests again, they give us information so we can make better decisions.
Yeah, and that kind of test is called pharmacogenomics, Like traditionally, healthcare system thought everybody processes the medicines the same
Right.
way. Let's give the same medicine to everybody and they're going to be okay. But there are small certain changes in some of the genes, especially genes that metabolize medicines in the liver. We call them the CYP genes, and they basically are different among individuals. And there are medicines that have a strong reaction to somebody because they are just missing that enzyme, or they have too much of something else,
Right.
or they could have like no benefit from the medicine when the doctors or the healthcare providers could just keep saying, no, you need to like
Yeah.
statins are one class of drugs that are used for managing cholesterol. And the way I use genetics to help with that is, one, we look for conditions like autosomal dominant hypercholesterolemia. Some
Right.
people just have changes in the cholesterol metabolism or receptors. No matter how much you make them exercise or
Or change their diet, eat more
diet,
fish.
they're going to
Right.
have high cholesterol. And
Right.
we need to like give them medicines differently. And the second test that we do for those families is pharmacogenomics, like how you were saying, where we
Right.
check for their genetic change and say, is statin a good option for you, or is there something else that we should be
Right.
doing?
It's so valuable because people will say, like, why did my doctor listen to me in terms of, why am I not having an effect? Or I told them I had side effects with this. But again, it's when we're hobbled, their doctor is hobbled by not having that information. It's hard sometimes to know what to do. So all the respect, it's just really hard to know what to do again without this information. So we
Yeah.
just really challenge everyone to know your risks and to consider getting tested.
Yeah, and a small example is I had a woman who got a carrier screening because they were trying to have a baby, so they wanted to know. The only result that came back positive was glucose 6 phosphate deficiency, so G6PD deficiency. Mostly when I'm calling somebody with a positive test result, they are either worried or they're like not
Right.
happy about finding that they have this isn't a condition that can affect her because it's an X-linked condition. So when I like joined the telehealth, she was beaming. She was happy to have found that she has G6PD deficiency. And I was like, what's going on here? And I
Right.
asked her, and she said, now I know that I was right all along. I have had chronic anemia. I have severe allergy to aspirin. I can't eat certain foods. And neither my family nor the doctors believed me. And they just kept saying, you're a woman, you're menstruating, you're going to be anemic, you don't eat well, eat iron, eat that. And now with the G6PD deficiency, here it was in
Right. She
front of
knows.
everybody. She felt validated. And,
Right.
I was surprised. I was like, this is empowering. I think this is great.
Right. It's just, yeah, it's huge because again, we know our bodies pretty darn well. And the more we, of course, can respect someone's opinion, the fact that they know their body, but then to have information to back it up. So now we know what else to do about it. It's just
Yeah.
huge. So
And
that was the other thing we were going to talk about briefly is the Gallery test.
yeah, I want to know more about it. I don't order it so much, but like, please tell us more about this amazing new test.
Sure. So as I've been taught, this test was first discovered by people doing looking at test results from drawing blood from mom to see if, for example, baby had Down syndrome. And the people in the lab were seeing the signal of the cell-free DNA. So, right, cells release DNA and it's cell-free, it's floating around in the blood. And so, of course, in these screens, they're looking for fetal DNA, right, to then test for genetic conditions. But the workers were noticing that there was these signals in the blood that was methylated cell-free DNA that they didn't know where that came from. And turns out they started to figure out that these signals were showing that the mom actually had an undiagnosed cancer.
Yeah.
And so the people that saw this then went on to further develop with all like much of the original research being done through Mayo Clinic. This is great, legit stuff. So Gallery developed this test that screens a person's blood for signals that could indicate that there is a cancer present that can't otherwise be detected. So, we screen in women for 4 main cancers, colon cancer with a colonoscopy, pap smear, breast cancer with a mammogram, and then maybe lung cancer if there's risk factors. But the Gallery test allows us to screen for pancreas cancer, ovary cancer, head and neck cancer, thyroid cancer. It's more sensitive for some cancers other than others. It's not very sensitive for very early breast or prostate. And so this test is used for people who already have other risk factors. For example, just being over 50 is the biggest risk factor for cancer. And so this test is recommended for people over the age of 50. If someone's 5 years out from a prior cancer, this is also a test that can be done to screen for recurrence, which can be, really weigh on the mind of people who have had a cancer in the past. So, we found that this test is very important, and this is a test that we draw blood for. It's not a swab; it actually is a blood draw. We've got to get the blood to the FedEx plane by a certain time each day, and that blood goes off to the lab. It's tested, and then we get a result that shows either yes, you have a signal, or no, there's no signal. If there is a signal, the company is able to use AI, artificial intelligence, to determine what region the cancer is coming from. So it's more generalized, like it's either coming from head and neck, from chest, from belly, from reproductive organs, from blood, or from bone. And so once we know the region of the body, then we can start looking for that. So we're really looking next week, we're actually going to go tour Banff again, which is a local regional center that does PET CT with rapid glucose uptake and testing for more specific cancers. So we're really excited to have Banff in town, in the sense of we can draw a gallery, and if we get a positive screen, we can partner with Banff to find that cancer early. So we're really glad to be able to do that, and it's really exciting.
And I was looking at the science. So they look at 1 million different sites for methylation. So next week when that dinner is happening for Banff, I think
you want to come. Are you coming?
Yeah, I'm also invited. Excellent. So the main important thing is this will become standard of care.
Yes.
At some
I don't know if you know. Oh, I'm sorry. Go ahead.
At some point, we will not be finding these stage 4 cancers, I'm hoping.
No, exactly. And where my mind just went is the company is now partnering with Medicare. So they had 3,000 people in Medicare. Medicare paid for the test, and then to see if it reduces total cost of care. Of course, if we find a cancer early, not only are we reducing burden on the healthcare system, we're not having to pay for chemotherapy, for surgery. But of course, the biggest win is that we're avoiding the need for surgery or chemotherapy for that person to have to suffer through. So it's very exciting. And hopefully, of course, these results will then indicate to Medicare and Medicaid that it's important to pay for these. I know that several companies, large companies, I think Google even offers this to employees. So these tests are coming. They're going to be mainstream. So we're glad at True to be one of the first offices in West Michigan to offer this test. And, it means a lot to be able to serve our patients this way.
Yeah. Amazing. Yeah.
So it seems like we've got a quiet crowd tonight. So if any of you have questions after the event or after the fact, please private message in True. We're going to show here on the side, I'm looking for Dr. Thakur's website address. I see it there. Yeah. So how do we reach you if people have more questions? How do they reach you?
Yeah, so we have made it super easy. So they can go to our website, which is genomeally.com, and they can book an appointment with me. And the phone number is 616-676-6879. Go ahead and call us. We live pick up the phone, and I can answer questions. We are also on all the social media platforms, so you can find us on the different platforms and reach out that way. Our email is connect@genomeally.com, so an email is also great. Because it's a telehealth platform, and we are interested in increasing the access. More questions, better.
Exactly. I love that.
I want to acknowledge Christy Todd's question.
Christy, I see you. Thank you.
Yeah.
So, hey, Christy. So I'm assuming you're thinking gallery. So the out-of-pocket cost for this test, again, I'm going to assume that you're thinking Gallery. Currently, it's $900. So of course that can be a bit of an ouch for the budget. I remember though when genetic testing was what, $5,000, and now
Yeah, at
out
some
of
point.
pocket's about $250. So hopefully this cost will come down. I know Gallery does have a payment plan as well for all of those listening and are interested. This is a test that can be done. We don't yet know what the frequency is. Is this a test that you would want to do every year? I had it done. It was negative. And it's just such a peace of mind. I think about even people we know. Katharine Hepburn died of appendix cancer, so even just to think that we didn't have to lose her to such, a cancer that is very difficult to detect, or ovarian cancer. So I agree with you, Christy, $900 is worth it. And it's one of those things we hope the cost will come down, but more than anything, we really hope that insurance companies will start paying for it.
Yeah, and the same thing with like other tests. All of these panels are usually covered by insurance, and if there is an out-of-pocket cost, it's like less than $300 for most of them. The same
Right.
thing for preconception carrier screening. They're very accessible and affordable tests.
Right. I am disappointed. I am adopted, as I shared, and Priority Health doesn't pay for genetic testing for people who are adopted. So I'm kind of disappointed, but I'm just gonna do it anyways. I really want to know, if not for me, for my children. So again, it's knowledge is power. And Mili, I cannot thank you enough for coming on our channel tonight to tell us all about genetic testing. And again, knowledge is power. And thank you so much for your work in this field.
Yeah, I appreciate the audience. I appreciate you. It was a nice conversation, and hopefully we can steer some women into taking proactive health decisions and take good care of themselves, because I thoroughly believe that if you are able to empower the woman, the whole family is all set.
Agree, 100%.
I see it all the time. Like, they're going to make sure that their partners and their parents and their in-laws and like the
Are
children,
all taken care of.
everybody is going to be on a good page if we are able to safeguard the woman.
Exactly.
So I appreciate the work you're doing at True, and then at Genome Ally, we hope to see some of your audience if we can help them.
Sounds great. It takes a village. So thanks for being in my village, Mili.
Thank you.
All right. Take care, everyone. Take care.
Bye-bye.